Today we'll talk a little bit about how we can fuse the virtual and real worlds really to better understand and treat postural instability and gait dysfunction in Parkinson's disease. So just as a disclosure, I am a recipient of the NFLPA grant, a consultant to Curate Health, and I've authored intellectual property related to both the AR and the VR applications I'll discuss today. So very quickly, Parkinson's disease affects about 1 million individuals in the US, continues to increase, right? Average age of onset, 61. It's increasing because the fastest growing segment of our population is 65 and older. So older adults, we're going to have more and more PD patients. Big thing about it, this slide is 2 points. One, at dot 3 there, that's fundamentally when you generally are diagnosed with Parkinson's. You've already lost 80% of your neurons in the substantia nigra. So from an engineering perspective, that's pretty good in the sense that you can lose 80% of your neurons and still be functioning pretty well. Now, from a restoration perspective, that's unfortunate because you only have 20% left, right? And so any restorative therapies are potentially compromised there. So that's why circle 1 there is also very important in terms of trying to identify prodromal markers to the disease. Today, I was going to talk about both, but I think in the interest of time, I'll just talk primarily about treating the symptoms after the disease. But if you want to talk about prodromal markers using some of the technology we developed here and the project we're doing, we can chat after the talk. 4 primary symptoms associated with PD: bradykinesia, rigidity, akinesia, tremor, and then postural instability and gait dysfunction. The one we're going to focus on today is really the last one, PIGD, because we do a pretty good job of treating the other ones with medication and deep brain stimulation. Jumping to the second point here, major challenge with PD is the effective treatment of gait and postural instability, right? So why do we care? Well, 80% of PD patients actually fall every year. So that's a lot. And if you have a fall, that, again, you're thinking 61 and older, so these individuals can break a hip, et cetera, be hospitalized. Falls are the #1 reason for transitioning from a home environment, independent care setting, to a dependent care setting. So the longer we can keep people at home, the better they are in terms of their health, quality of life, et cetera. What precedes a fall? Lots of things, mostly cognitive dual task functioning, but freezing of gait is a big deal. So freezing of gait fundamentally is where the individual is frozen, right? So many patients will describe it like their feet are nailed or their feet are glued to the floor. And so, they know they want to walk, but they can't walk, right? Because they're just stuck, they're frozen. So why can't we treat this very well? Well, one of the reasons is we really have a fundamental lack of appreciation from the dual task functioning that is necessary or performing that's necessary with gait tasks, right? So you think about gait is not just a motor activity, right? You walk across, as I was walking over here from the clinic, certainly large motor component. I had to cross 2 streets, right? Well, 3 streets. I jaywalked on one. The other one, I used the crosswalk and the button. However, I still had to process a lot of information going across that second street because there were cars coming. Are they actually going to yield or stop for me in the crosswalk or not, right? So you're processing information to get to do these different tasks. And so I think part of our failure in terms of really treating postural instability and fog is the lack of understanding what's going on from a dual task perspective. So I won't go through the different models of freezing of gait. We'll save that for another time. But fundamentally, all of these models, what they have in common is there is really a disconnect or a dysfunction in the processing of information, either the amount of information or incongruent information, or disconnect between a stimulus and a response, and motor planning or motor activities as well. So that is what really these models have. And there are probably 50 or more slight alternatives of these models. So then the question is, what happens to gait when people are doing a dual task. Uh, Turns out it doesn't really matter what dual task they're doing in walking. So we published this in 2019 or so. Whether they're doing a gait task or any other type of dual task while walking, serial sevens, digits, recall, Stroop, etc., all hitting different types of cognitive functioning, there is a significant decrease in their gait speed. So they have this global deficit in dual tasking. So how does this then relate to PD and keeping individuals independent and evaluating freezing of gait? Well, we think about this from a instrumental activities of daily living. This is different than your typical ADL. Typical ADLs are bathing, dressing, things like that. Instrumental activities of daily living, these are the things that keep you independent. So these are the things that your grandpa and grandma over there need to be able to do to not go into a dependent care setting or a nursing home, right? You got to be able to drive. You have to be able to cook, do your laundry, do shopping, manage your bills. Many of those, maybe bills not so much, but have a cognitive component, right? You're driving, got to process information, got to make a response, and you have a motor component. Same with shopping. So what we did is, looked at the different things out there, and really, it's very difficult to objectively quantify IADL function through measures, through surveys and things like that, because it's often based on, one, their perception, and two, some other, like a spouse, answering for them. So really, if we really want to observe fog, or we want to treat fog, we have to observe it and see it. So why is it difficult to see it? Well, anyone who's been over at the Cleveland Clinic knows that we have a paint called Cosgrove White. Toby Cosgrove was our former CEO, painted everything white and made everything perfectly straight, perfectly aligned, right? So you look at a picture like this, and that's not an environment that's going to trigger fog, right? And our clinical environments are not designed for that. What they're designed for is patient flow. How do we get as many patients in and out as efficiently as possible? So the problem then is our neurologists aren't seeing episodes of fog that the patients are experiencing in the real world. So our approach was to use technology, augmented reality and virtual reality, to create environments that could induce, or hopefully induce, freezing of gait and postural instability. Quickly, augmented reality, placing digital objects in the user's real world, heads-up display on a car or the Amazon app to see how the chair will look in your living room. Virtual reality, completely immersive in that digital environment. So 2007, National Academy of Engineering had these grand challenges. One of them was to enhance virtual reality and integrate it into healthcare. I would argue that we have not done that very well. There's certainly some examples of surgical planning, and there's examples of even kids using VR to do art or things in the hospital, and those are nice, those are fine, but I don't think we have fully captured the capabilities of engineering systems or of virtual reality systems. One of the reasons is because of the locomotion problem. Locomotion problem in VR is what causes cyber sickness, right? So if you used a VR system, you have a disconnect between your visual information, somatosensory information, and other sensory sources, right? Vestibular information. And that's why people get sick. So what we have done is we have looked at trying to address this through the use of a omnidirectional treadmill. And so here is an example of me walking on this treadmill. Normally a treadmill is a linear component, right? So it only goes in one direction. The omnidirectional has a linear component and a rotary component. So what it does is it can go in both directions. So what you're doing is I'm wearing a little puck on my waist, and there are 3 cameras that keep, the goal of the system is to keep the user in the middle of the treadmill, right? So if I take a step this way, the treadmill is moving this way to keep me in the center. And so the nice thing about it is you can actually now potentially physically navigate a virtual environment. And again, in PD, you saw me do some turns there. In Parkinson's patients, that's a big problem. Turning is a big problem. So we were optimistic that we could potentially look at freezing and postural instability using this technology. So here is our setup. We developed something called the Cleveland Clinic Virtual Reality Grocery Shopping Task. So the first thing we did is we paired with a occupational therapist. We went out to a grocery store and we evaluated what people do as they are shopping, right? And so we broke it down into, we did a task analysis, motor component, cognitive component, and cognitive motor component. So, right? Simple walking, motor, and then you have to observe, study the list. That's more cognitive. And then a cognitive motor is navigating and reaching and grasping that object and putting it in the cart. So there's different combos there. So fundamentally, that is what we have created in terms of a virtual grocery store that individuals can navigate through. Different components here. Again, there's a picture of the PD patient using the doing the task. What we wanted to do is have a couple cognitive and motor tests, right? Or challenges, right? In the sense that, so we have a sale item, right? Which of these is more cost efficient? And we have different levels of easy, medium, hard. This would be an easy one, right? So the patient has to select which one is more cost effective. So obviously it's the $1.50 for 60 or with 16 ounces. So what we're doing though is we can look at the time that they're deliberating in terms of figuring out, do they want to take this one or that one? So again, looking at cognition. And then at the bottom, you can see we've built a scenario where they have to go through a narrow area, right? So again, something that causes a level of anxiety as well as freezing of gait. So here we have an individual with Parkinson's actually doing the task, the virtual store. They're walking. You can see he slows a little bit as he's going to come up to between the fellow shopper and the cart. And then he's going to look at his list here in a moment. So we are capturing all of his hand movement as well as obviously the biomechanics on the walking. And as he grabs the item, puts it in the cart, we can characterize how much time he is spending looking at the item, his reaching and grasping time, release time, et cetera. And so now he's going around the store. And what we did is we built a course that's 200 meters, and they have a green line that they have to follow because all the items are on that green line. So why didn't we just let them, go navigate throughout the store? Because we didn't know how long it would take them, right? And we really weren't interested in their navigational skills per se. So this way we have 200 meters from everyone, which has been served us well. So here we have just a recent study we completed, 15 PD patients, 15 healthy controls. Again, main thing to look at here is that these individuals were relatively mild, UPDRS of 30, most were at Hoehn-Yahr 2, so from a classification perspective, that's still a mild disease. You got to remember we selected mild PD patients because we had no idea if this was going to work or if PD patients were going to be getting sick or whatever during the course of this. So we really wanted to get patients who were not overly impaired at this point. And we did a battery of traditional cognitive motor assessments. And what we found, not surprisingly, because these were pretty good patients, not very impaired, was that these traditional tests clinical assessments did not differentiate or discriminate between controls and PD patients, which we would sort of expect because they're not that impaired. Then we had, here's a top-down view of the performance of individuals, a PD patient and a control on the left, the patient on the right. So what we've done is we have been able to, so we look here, this is a 20-meter walk where they're fundamentally doing nothing. They just have to walk down a giant aisle in the store, and we use this as their baseline walking speed because there's very little distraction there. They make the turn, and then they go and look at their list, or maybe they don't look at their list, but they are then instructed to grab 5 different items that are on their list. 3 of these items have sail items like I talked about before. So we have their path there, and the green represents just walking. The blue represents them walking while viewing their list. So that's a dual task. You're viewing your list and walking. The red represents when they're stopped. In this case, the control is grasping an item. And the yellow is when they are stopped and not looking at their list. So what we see here is, this individual, healthy control, a lot of green, and then a lot of when they are looking at their list, they're still walking. So they can dual task pretty well. Now, when we look at a PD patient, what we see a couple things. One, does this just fine, has a stop here, that's fine. Then a list view, and then these red dots here represent where they're stopped. So again, what you notice, you have more yellow list views. You have fewer time when they're actually simultaneously looking at the list and walking. And we also have more red portions here where they're stopped. So the question is that possibly a freeze? And so that's one of the things, and I'll talk about another paradigm that we're using. But fundamentally, you can also see that there's a lot of these stops and a lot of the yellow components here. So again, quickly, just going through the global performance metrics, PD patients were significantly slower, right? So the question is, why were they slower? So they were slower because they had clearly some motor problems. If you look at their speed, average walking speed, 0.25 versus 0.20, again, meters per second. Now, if you'll notice, or if you have any understanding of gait, you also will say, wait, that seems kind of slow. And it is slow, right? So walking on an omnidirectional treadmill while you have this virtual environment, and we've had these studies done, gait speed slows down substantially for young, old, and PD patients. Now, what we did, not in this study, but an earlier validation study, is we looked at the kinematics of walking. Despite them being slower, there was a preserved kinematic pattern of walking. So in terms of the joint angles and such, they were very similar. They were just slower. They just walked slower. So I would argue that we're still evaluating gait. It's just everyone is a bit slower. Turning time, again, big issue for PD patients. They were spending 163 versus 118 seconds turning. Cognitive performance, total time observing the list wasn't different, but the number of list observations was different, right? So you notice those yellow dots before. They were looking at the list more frequently than controls. Now, this is despite the fact they had the same trails time, the same MoCA scores, the same other processing speed scores in clinical tests. So again, I think what this is building to is this is much more salient assessment of function, provides us with much more precise information about gait and postural instability to some degree. And then again, when we look at these dual task metrics, the total stop duration was significantly greater, so they spent more time stopped, as well as their gait speed while walking. So while they were doing a dual task, they were significantly slower than the controls. So again, I think it just goes to this fact, or this point, that dual task functioning is impaired, even though we don't see cognitive impairments that are real clear through standard clinical assessments. So then the next section is, or how do we leverage this technology? And those stop times were not that long, right? Some of them were less than 5 seconds. And so it's a freeze, but is it a freeze or is it a pause to look at something? So thinking of that, we thought, well, how do we create environments, again, based on those 4 models of freezing, that would be even more effective at potentially triggering these freezing episodes? So one of the things we did is we created a home environment. We went to Bob's house, we filmed his kitchen, and the patient is instructed to walk in through the kitchen, and now they have to go through this door, right? And so you see it and you think, oh, that they just have to walk this plank and make a turn, and it's not that big a deal. So we were trying to increase the anxiety, right? Because that's also when PD patients freeze. But we knew this worked when the first patient who used it, she got up there and the door opened and she started to swear at us because she's afraid of heights. And she was like, I'm not effing going through there. So it was very interesting, and we're also monitoring heart rate, so we can see that there's a significant increase in their heart rate as well. So we're definitely inducing anxiety, and so we built 2 more scenarios: decoupling and physical, as well as cognitive and decoupling. So decoupling, you hear a lot when PD patients go through a doorway, they freeze, or a narrow area, or if there is a change in the flooring, right? So we have it going from wood to slate, and they get smaller, more narrow hallway, and then when they turn and come back to the kitchen, it's even a more narrow hallway. And then the cognitive and decoupling, that is very similar to like a Stroop test. In this case, the patient has to identify the animal that is shown there, right? So on the right, it's a bee, but there's an incongruent stimulus there, chicken. And they have to, right? So it's sort of a cognitive stressor for them to come up with the right answer. Here, what we've done is now we are not only doing the VR, but we are also recording with the deep brain stimulation electrode in DBS patients. So Medtronic has the Percept system where we can go into the subthalamic nucleus, and we are actually recording, when the stimulator's off, neural activity, LFPs, local field potentials, from the STN, which is an area where you also stimulate for DBS. And on top of that, we are gathering EEG, 64-channel EEG from the individual as they go through the shopping task as well as the virtual home environment. So again, there's a lot from an engineering perspective. There are a whole bunch of systems and triggers that we had to create and to ensure that there was synchronization between all of the data. Happy to talk about that later. But what I'm really excited about is we have 9 patients so far, and we've had more than 125 episodes of freezing, and there's 15 minutes of neural data when patients are frozen, which is phenomenal in terms of the amount of data that we actually have. So we have a little bit of that data analyzed. Here's an example of an individual doing that task I showed before. They're walking out across the ledge, and then they do a 180-degree turn. So we have a clinician there who is identifying when someone freezes, clinical observation, and that is in the gray boxes there, shaded gray boxes. So this person had multiple freezes, and then you can see when they made the 180-degree turn, they were also having these freezes. Now we've also instrumented the patient with markers, so we're confirming that these clinician-derived or identified freezes are actually biomechanical freezes as well. And in general, there's pretty good agreement with our algorithm. So we have now looked at data from a couple of the patients, and we're super encouraged here in the sense that, we identify the walking pre-phase or pre-freeze and the freeze, and then the post-walking or the post-freeze. And what we have, so this is just raw data from the right STN LFP data that you can see, and then we've just highlighted the freeze here. And then we look at the power and the frequency, and what we see is during walking, normal walking, and post-freeze walking, fairly normal patterns of neural activity. However, when they freeze, we have an increase in the synchronization in the low beta phase. Right, so this starts to look like this could be a neural signature for freezing of gait. Again, this is I think 3 patients here, and we still have a ton of data to analyze. But the fact that we are starting to see differences between freeze and not freeze is super encouraging for us from multiple reasons, and I'll go into those. So I'll go quickly through this next section in the sense of, because I want to talk a little bit about the AR. But so now that we can trigger freezing of gait and actually see it,
And I would argue that this is clinically viable because we have one of these systems out in Sheffield right now, Sheffield Family Health Center, and a number of individuals have already gone through it who do not have Parkinson's. So it's like a 10-minute assessment, and we get tremendous data from it. So now that we can trigger it and see it, how or can we treat it, right? And so we have done in the past a clinical trial to show that you can treat PhD in Parkinson's through very intensive one-on-one physical therapy, dual task physical therapy, 8 weeks, 6 or 24 sessions, et cetera. And it actually works like a champ. The problem is people don't use it, right? So they did a study, the Domingos did a study, and with neurologically trained PD therapists, 90% of them were trained in providing this type of therapy, and less than 60% actually used it because it's time consuming. Tailored interventions are difficult to create. It gets boring. How do you keep it challenging, motivating, et cetera? And there was poor compliance and motivation. So again, we thought, can we use technology to potentially enable dual task training? And so what we did is we created something called the DART, the Dual Task Augmented Reality Treatment Platform. That really has both a clinician interface and such. I won't go through the whole sort of infrastructure here, but I'll just show you a couple things. One, we don't have any evolutions that we're going to take the place of a physical therapist, but that's why we said it's your digital provider. By the way, Donna is my mom, so named after her. So really what we have is we have this, again, now it's augmented reality, right? So they have HoloLens 2, and they can see the rest of the world, and this therapist is bringing them through different dual tasks to do. So what we have is an example here.
Airplane wings. Say begin when you are ready. Say repeat to hear the instructions again.
So this is a dual task, right? So Donna was asking him to say, what do dogs and trees have in common? Bark, right? So I didn't hear that one. But anyway, you can see we're challenging them from a cognitive perspective and from a motor perspective, so they have to attend to both, right? And they have to avoid these obstacles, go through the doorway, et cetera. So that was our embodiment of dual task training in an AR set with an AR. I'll just skip through that. So our real fundamental goal was then to see, can we create a digital therapeutic for the treatment of postural instability? So the way you evaluate a digital therapeutic is you have to do a validation study with a known treatment that has already gone through randomized controlled trials. And so we did that previously with our one-on-one trial. Now we were comparing that, the traditional dual task therapy, one-on-one with a therapist, to our DART or our augmented reality therapy. And importantly, what you do is you power it, is you are powering and looking for an equivalence between the two, not the lack of a statistical difference. Because what you want is you want them to show that both are equivalent and there's value associated with the DART or with the technology trial or the technology. So again, real quick. So this was we just published this in Neurorehab, Neurorepair, the first digital therapeutic for the treatment of Parkinson's gait dysfunction. And what we see here on the left is simply gait velocity for the traditional and DART groups at baseline in the lightest blue, and then at end of treatment. So both groups went through 8 weeks of therapy. One group, the traditional group, had one-on-one with a therapist. The other group used the DART system. And both groups had a significant improvement in gait velocity, as well. Those improvements were equivalent to one another, statistically equivalent to one another. So that was, again, just gait velocity, same kind of thing with step length. And importantly here, we were looking at EOT 8, so end of treatment plus 8 weeks. The nice thing about it is that these, not only were they statistically better, they were also maintained, right? So these improvements are maintained. So it actually goes and it makes us think that we're actually changing brain function. We're not just bringing someone through PT and getting their legs stronger or something like that, but maybe we're changing brain function. And that's where, I think it gets really exciting for us from a next steps perspective. So real quick from just a summary, I think PD patients certainly can use AR and VR technology. So what we did for our DART study is we looked at something called system usability score, right? So this is how you evaluate technology. And these are iPhone applications and where they rank. Generally, if you're over an 81 or so, it's considered good to excellent. And the DART project or DART system was, 82 or so. And just relative to, so we're as good as Words with Friends or Temple Run, and we spent a whole lot less money developing this than they did. So PD patients can use technology if it's developed with the end user in mind. So you guys may have grandparents or maybe your parents, I don't know, but you think, oh, they can't use technology because, well, their VCR a long time ago was flashing 12 all the time. Guess what? The way to change the VCR time was horrible, right? So it was a poor interface to try to get something done. And so if you design something with the end user in mind, you have a much better chance of actually being able to get them to use the system. And so I think, we brought a lot of PD patients in through the development process, had focus groups, and they provided great information for us. So I'm 100% convinced that PD patients can use this technology. You just have to design it with their limitations potentially in mind. Again, I think the use of VR to create these salient environments is critically important, and we can actually trigger freezing of gait and postural instability, and that's going to help us treat it better. And, again, it looks like there's this increase in this low beta that is underlying both FOG and PIGD, and I think we can potentially treat it. So to me, what's super exciting from a next step is really trying to understand this mechanism of FOG as we get data from the STN. And then, looking at, so we have a project that will be starting soon, where we're going to put patients through the DART training and monitor their neural signals before training, give them 8 weeks of training, and then what happens after training. And are we potentially changing patterns of neural activity or the network? We're doing the same thing with exercise. How can exercise, aerobic exercise, potentially change neural activity? So for us, having something like the Medtronic Percept system is super critical in terms of helping us really answer these fundamental questions. And then our long shot, if you will, people talk about, I want to develop an exercise pill, right? What are so you just take a pill and get the same effects of exercise. We're not trying to develop a pill, and I don't think we're really trying to develop exactly DBS to substitute exercise. But if we can identify, right? So we've shown, and others have shown, that exercise actually can slow the progression of PD. And so if we can develop understand what's going on with exercise, and then develop a set of DBS parameters that can replicate the effects of exercise from a neural perspective, will it have the same effect, or will it have additional effects? So again, we're super excited about hopefully these next steps, and hopefully NIH is excited about some of them as well. So, but again, happy to talk more, and have to acknowledge all the folks who really do most of the work here. But happy to answer any questions, and also if the students have questions or want to hear more about it, definitely reach out, send me an email. Happy to chat more. So that's all I have for that.
That was really cool. I was curious about for the Down balance beam exercise where they have to go to the platform and turn around, is it necessary to enforce like a consequence? Like if that weren't virtual reality and you step to the side, you would fall.
For sure.
Did you enforce that in the way, like, was there a consequence in the way that it was designed? And if that
Yeah, we thought about that. We thought about, do you have we certainly can't have them fall off the treadmill, right? But we were thinking, oh, could we link some vibration or something like in lane changing or lane keeping for cars. But we ended up not doing that for a variety of reasons. But so I'm not sure for how that would impact it with that extra stimulus coming in there. But I think they really felt that they were in the environment, and the fact that they're freezing and that the lady who was afraid of heights, really didn't want to do it. Makes it fairly immersive, but that's a fair point.
Yeah, it's very interesting. I like the idea of recording from the brain. Do you think this could be applicable in determining the efficacy of the treatment for Parkinson's?
Yeah, so the question was, could we use the technology and the brain recording to evaluate efficacy and of a treatment? And so what we're planning to do in the CNR is for individuals who have DBS or are considering DBS, having them go through this as a baseline, and then potentially trying to figure out, can we use this to tune stimulation parameters, right? The upside is it's a fairly short exercise, and we could make it even shorter. But can we start to tune stimulation parameters to something that's meaningful as opposed to just finger taps, right? We do it with finger taps because it's easy, But this, I think, so we'll see. I think so. And I think it'd be really patient specific, which is super cool to me.
Great talk, Jay. Two questions. Your first study you shared, where it's like really mild, mild early stage, and then you kind of had the great outcomes where you were able to elicit a number of freezing episodes. Are the demographics in those two cohorts the same? So are those also?
Yeah, no. So the second group I showed, sorry about that. Exactly, they had DBS, so they're more advanced in their stage. Ages, a little older. Education the same, but years with DB or years with Parkinson's more, and higher UPDRS scores. Yeah.
Great. Second question: your DBS participants, do they all have leads in STN, or do you have people that may have leads in other locations?
Yeah.
There's kind of interesting work in some of the different nodes.
100%. Yeah. Right now, we just have STN patients, and because Medtronic, they were approved in 2020, so we're, those patients are like gold. And I don't know who's implanted. I don't think we've done any GPI placements for our patients yet.
First, Doug, I was curious if you can speak to accessibility of these platforms, especially for other researchers. I'm working with folks with lower limb amputation. I'm curious if we can get access to what you have developed.
Oh, for sure.
Specific to clinic.
No, for sure. We're neighbors. So let's see. I think Dawn Taylor had her hand up virtually.
Can you hear me?
Yes.
Oh, okay, great. I was starting to type my question. Anyway, just really great talk. I was very interested in your 7 hertz peak there. I know we're trained to think about beta when we talk about Parkinson's, but in reality, that's kind of like a low alpha, upper theta peak.
Yeah.
And I guess I was really intrigued because I saw that exact same thing in one of my PD rats, who actually, and he would freeze too, but I didn't know in a rat if it's just sitting there zoning out or actually freezing. It's a little hard to tell, but this really is kind of a confirmation that that's was potentially impacting its behavior. I mean, these were really, really noticeable, strong 7 hertz bursts, and the rat would just like sit there.
Oh, yeah.
So I will definitely take one
Yeah.
look at that data, because that's pretty interesting. Do you have any thoughts on why 7 hertz, what's going on? Is it really a motor thing, or is it just a kind of overall brain freeze, literally? I mean, you know, just zoning out that takes them out of what they're doing? Or is it a motor thing, or do you know?
Yeah, we don't know yet, right? We just have these 3 patients we have analyzed, and we haven't looked at their cortical data yet. So that also will be interesting to see what's going on from a network perspective. And yeah, we should definitely talk about, because, and you're right, I said low beta, probably should have said alpha. The problem is, there's a little, there's wiggle, yes. So, yeah, so for sure, I don't know, it would be interesting. Actually, it's quite interesting to see it or would be seen in your rats. And we could think of how we could really look at both systems together. Yeah, but we're honestly, so I'll be honest, we're happy no one got sick and, vomited, and that we're actually able to induce freezing. So that was a win for us.
Very cool.
So, for what it's worth, and Jay, this is also consistent with some work that actually done with the University of Florida. So I think their leads were in ppm, but they also saw a marker that was in that like 2 to 8 hertz range that seemed to be somewhat correlated with gait. And so, yeah, I think there's something.
Yeah, for sure. Oh, sorry. Another question in the chat, sorry. Oh, yeah.
The onset of FOG from the IMUs appeared to be the preset of synchronization with the IPG and the environment. I'm curious how you're establishing synchrony, whether programmatically or through hardware or both.
So first through hardware. And so there's a sync pulse that we use, the TENS pulse that is sent to the DBS system, the EEG, and to the Unity controller. And then we verify it programmatically. But yeah, it was a big problem. It was a challenge, and I'd be happy to. I think Mandy Coop from my lab is actually writing a paper on it from a methods perspective.
I have a question.
Yeah.
Right at the end, you talked about doing DBS to avoid exercise, it sounded like to me. Wouldn't it be sort of the blood flow and all, more of a systemic thing than specific neural thing?
It could be, right? But because it's interesting. So Bob is suggesting not DBS for exercise. But no, I'm just saying, but I'm just, but yeah, certainly you have increased blood flow with exercise. The interesting thing about it is we don't know if that's driving this change in neural activity that we get with exercise, right? So we show these changes much after they finished exercising, changes in the connectivity between the cortex and the basal ganglia in those who exercise versus those who don't. But yeah, it's a very reasonable.
It seems like there's an autonomic.
Yeah, no, for sure. And I think, to me, I would never suggest DBS over exercise, but if it could augment, right? For some of those patients who can't exercise very well or have very bradykinetic movements and can't exercise at an intensity, maybe we could still get some good, outcomes in that sense. But that's a fair point. I was being a little facetious as well.
Are there any online? Oh, we have one here.
Yeah.
I was wondering if you can talk a little bit about how you choose your cognitive assessments in your tests. Like you had kind of like an animal Stroop test, and then towards the AR system, you had more of like a riddle type thing. Why, like, how do you choose that, and why do you choose that over like more standard, like just like a color Stroop test, or like an auditory Stroop test?
For sure. Yeah, so we looked at the auditory Stroop, and what we did, so I didn't talk about it in the virtual home, we have them in that case, they have the controllers, and they do left for or congruent, right for incongruent, right? And so that was a really nice, and there have been other papers that look at this picture context interference, and so that's really where we used it from. Because we had, in our other studies with AR, we did do a color Stroop, and the problem was the voice recognition. And PD patients are somewhat hypophonia, so we weren't always getting data. And so then it was like, well, wait, are they correct and we just didn't hear it, or are they incorrect and we just didn't hear it? So we tried to do it in that regard. And then I only showed in the AR one of the dual task component, the cognitive components, but we have 14 different cognitive components, if you will, that we can pair up to the various motor. So they weren't just walking around, the obstacle course doing that task. There's a variety of tasks that they can use. But the reason we select is, so again, back to that earlier paper I showed in 2018, Serial 7s, Stroop, et cetera, they all resulted in this dual task loss. And so in some ways we try to select a broad base or broad number of cognitive tasks to assess and train different aspects of cognitive functioning.
Thank you.
Okay, Lisa, do you have something for our speaker here? I'm not going to let you go.
Okay, all right.
Unrewarded.
Oh, well, thanks. And I will come back sometime in a year and give a
We have
less rushed version as well.
a little token of our appreciation.
Oh,
for you, Jay.
all right, thank you.
Thank you
I
for
appreciate
coming
it. No,
and
I
being our
appreciate it.
first
Always,
speaker of the year.
Fantastic.
And secondly, putting up with our
Well,
confusion here. You did a great job.
no worries. No, I appreciate it. Thank you.